in large part because we haven't been able to do RLR VMR for a little while. I'm hopeful that we get to do that today, and we'll see Prof. Rez in a minute or two, but I haven't heard from him, so we'll see. Fingers crossed. As always, would love to see if anybody in the crowd has a case that they want to present today. If you do, please let us know via the chat. In the meantime, I will ask our dear Yasmin to tell us what beverage she's so delightfully enjoying.
Just plain coffee.
Oh, just straight old coffee, huh?
Yeah, with some oat milk because lactose intolerance. Yes, but some coffee.
How do you go about making your coffee? Are you like, is it important to you how it's made, or you're just like
it is.
Oh,
I a new mocha for Christmas. It's like a little, I don't even know how it works. I believe it's like thanks to pressure or something. But I'm starting to get into that world of like coffee and barista stuff. And whenever you visit me here in San Antonio, any of y'all, I got you.
Oh my gosh, that sounds amazing. Are there any other like coffee people in the crowd? By coffee people, I mean like Yasmin's level of coffee people. Oh, I think Bia is one of them. Tell us, please.
I'm Italian, so I think every Italian is very affectionate and very attentive to how a coffee cup has to be made. But me in particular, I mean, I couldn't live without coffee.
Yeah.
Like literally, it's my only way of keep working every day.
Oh, incredible. Wow, two people. And I didn't want to generalize, but I think it's so true that my mom went and spent like a whole year in Italy, or no, not a whole year in total in Italy when she was younger, and she talked about how like you just never have coffee the same in the rest of the world. So cool. Yasmin, you're getting some recommendations from a friend from Venezuela, Huting, who was nice enough to message me earlier today. It's nice to see you here. I don't know if you can unmute and say hello, introduce yourself to the team, but you should if you can.
Hi.
Hello. How's it going?
Hi. Good. Oh my God, this is actually my second time listening to this live chat. I mean, yesterday was the first time, and I was blown away because I am currently studying for step 3.
Mm-hmm.
So yesterday was so educational, and I learned so much. It's like the way how you think through just one phrase. It's like, okay, this patient with abdominal pain, this, and then you just disclose everything. So I don't know. It's just
You're
very
making
helpful.
Leah blush here. You're making Leah blush. Look, blushing.
Oh my, but it's just I'm trying to keep up. I mean, everybody is doing such a good job, and it's really hard. I mean, yesterday the presenter, she was so nervous, but she did a great job.
Right.
And but it's very nerve-wracking. I mean, it's too nervous, like to be in front of everybody who knows so much. I feel like, oh my God, I know nothing.
Well, you know a lot more than you're giving yourself credit. Where are you calling from?
I am from Cleveland, Ohio.
Incredible.
I mean, I graduated from medical school in Venezuela, and I moved here a couple of years ago.
Awesome.
And yeah, I mean, I'm so glad to found this group, and I think I'm gonna learn so much. So thank you for letting me talk a little bit. So hi everybody as well.
More and more every time, I hope. You know, VMR Legend is here to present a case to you all. I've kept it quiet, but Hans volunteered to he has what he said was a 30-minute gem, but given how much I babble, I think we can easily make it an hour. So Hans, thank you. We'll have you reintroduce yourself because there's some new people here, and kick it away whenever you're ready.
Yes, my name is Hans, and I'm a recent graduate, or not so recent, from Ross University. And I try to match either in the US or in Canada, I'm not sure. So today's case, I have given it a theme just the way that Kirtan does it. And it comes in, I think, 4 aliquots, and it's not that difficult. So the theme is an embarrassing complaint. The chief complaint, I have an 18-year-old, so 18-year-old male who, okay, I have an 18-year-old male who presents with priapism for 20 days. You never had something like this?
Oh, not at all. Yeah, no, I don't think we've had, I think that in general, pelvic and urological complaints are hard to find in VMR. And I felt that because recently I took care of a patient with pelvic pain that I realized that I didn't have many exposures in this domain. And yes, 18 days of priapism is not something that we encounter on VMR a lot, but it is probably not too rare in real life. And I think what priapism fundamentally represents is a persistent erection for longer than is physiologic, and 20 days sounds extreme. And so I think the key question with this is to wonder whether the patient has had true continuous priapism for 20 days or whether it's been intermittent and just not fully receded over 20 days.
Okay.
But the fundamental lesion with priapism is impaired outflow. So there is outflow obstruction. And the question is, what is doing that outflow obstruction? And there are many disease mechanisms that do that, but that's the theme. And so we'll pay attention to the risk factors that are mitigating this outflow tract obstruction, be it medications, neurogenic, or intrinsic vascular issues. So Hans, tell us more.
The patient reports a persistent erected penis for 20 days. There was no phase without an erection, a relaxation in between. Patient denies a history of trauma due to sexual stimulation or otherwise, nor consumption of drugs. Patient also complains of mild genital pain along with the erection. No complaints about discolorization of the penis becoming reddish, bluish, or pale. He denies numbness. Patient is able to urinate normally. And I have a second aliquot that belongs to the HPI with the past medical history.
Thank you, Hans. Yeah, no, I'll just reflect on here. So at the end of the day, what we're trying to distinguish with priapism is it's helpful to understand the pathophysiology just a little bit. And so if we're just strict about the definition, when do you call something priapism? You call something priapism when a patient has had a prolonged erection. Now, what does that mean? It means that the erection has lasted for more than 4 hours. So the first pass is, are we truly dealing with priapism? The answer is absolutely yes. Now, the theme is actually very simple. We know that there is too much blood in the penis. And the question is the blood there because it is stuck? And that occurs because of outflow, usually venous obstruction. And that, believe it or not, accounts for over 90% of priapism. So venous obstruction, either at the macroscopic or the microscopic scale. The other form is called non-ischemic priapism. And that has to do with just a much higher blood flow going to the penis without obstruction. And the reason that gets rendered non-ischemic is there's literally no obstruction to cause ischemia. So that form of priapism is much less common, but usually actually resolves by itself. Now, why does that happen? It usually happens because there's an AV fistula. So an AV fistula connects the cavernous artery to the venous outflow tract. There's more blood going into the penis, but there is no venous obstruction, so there's no risk of actually getting significant complications. So that's the key question. The key question is this ischemic or non-ischemic? And again, ischemic is much more common, venous outflow tract obstruction, and 5% of cases are because of an AV fistula causing high flow priapism. It's actually honestly analogous to heart failure. If you think about heart failure in two mechanisms, low output cardiac failure, where there's a blockage of some kind causing backflow, versus high output cardiac failure, where there's failure, but there's no obstruction. And so at the end of the day, when you're thinking about what causes the venous obstruction, it's usually medications. And those medications, I think, are become infamous because of common use and advertisement, which is the phosphodiesterase inhibitors. So if a patient's taking a combination of nitrates and phosphodiesterase inhibitors, you'll have to think about that. But there's some other medications that do it. In terms of the vascular hypotheses, you're thinking about venule occlusion, and the most common cause is sickle cell disease, be it overt sickle cell disease or sickle cell-like diseases like hemoglobin SC combination or thalassemic hemoglobinopathies. So I think the key analysis for this case diagnostically is to look at the medication list and to see if there's evidence of a hemolytic anemia. But in this case, it's usually much more important unless you're dealing with non-ischemic disease to initiate therapy. So these patients are an urgent call to urology for empiric management. And that empiric management has to do with bypassing the venous obstruction and draining the blocked venous outflow. So I think key questions are, what are the meds? And is there a family history or something to suggest sickle cell disease? And if we bypass those two things, we'll have to think much harder. Okay, Hans, tell us more, please.
Yes, I have a second part of the HBI. Patient also complained of tinnitus in his right and left ear for 15 days, accompanied by blurred vision. Patient also felt subjective that his left side of the stomach was slowly enlarging for 5 months. He denies bleeding and fever. Before coming to the ER, he was hospitalized at the regional hospital and received a blood transfusion and was diagnosed with a blood disorder. Now, the past medical history I would like to bring as well in this aliquot. The past medical history is unremarkable. He had no surgeries, no vaccinations, and everything is up to date. Patient is on no medications. Family history is unremarkable. And social history, he's a senior high school student. He likes sports. Now the next aliquot will be the physical exam.
Prof. Rez is here. What's up, Prof. Rez?
What up? Hi, everyone. Hans, so nice to see you presenting, my friend. It's the first time I get to discuss one of your cases. And of course, it's a chief concern I've never thought about. Besides, if you ask me what was my approach to priapism, I would say sickle cell disease or Viagra. But we're going to learn much more from this case. I think with this second aliquot of information, it's extremely helpful because it tells us we're not dealing with an isolated problem to the penis, but a problem that extends beyond the penis. We're getting clues of extra penile involvement. And that comes in the form of this left stomach swelling, the tinnitus, and the blurred vision. And I think that if you start with enlargement of the left stomach, what that suggests to me is one of two possibilities. Either there's actual gastric outlet obstruction or something that's causing the abdomen to distend, which I think is less likely because there's no nausea, vomiting, or the more likely possibility, which is enlargement of the spleen. So I wonder if that is a clue to splenomegaly. So the physical exam is going to be very important. And even if my exam doesn't detect an enlarged spleen, I have such a low threshold to pursue imaging in the form of an ultrasound over a CT scan, just given his age, but maybe a CT scan. Then you talk about blurred vision. The approach to blurred vision is to basically determine if this is an issue with refraction or is it something beyond refraction. And I'm assuming, Han, I'm going to make the guess that this is bilateral rather than monocular. It's binocular. That's a huge branch point because if this was just a monocular issue, you can localize the pathology to the single eye. And the way you can distinguish binocular versus monocular is to cover up. I'm laughing a little bit because Robbie, he discussed priapism, something we never discussed, and I got to talk about stuff we talk about often. But basically, you cover one of the eyes, and If it resolves, it's a monocular problem, so the pathology is in the eye. The reason I don't think that's the case here is because we're already getting clue for extraocular pathology, so we're dealing with a multi-systemic process. My approach is going to be binocular blurred vision, and it would be odd for someone so young to suddenly develop blurred vision because there's an issue with refraction. So I'm going to even make the leap beyond a refractive issue to say that we're not dealing with refraction or the lens in terms of refraction, but we're actually dealing with pathology. And so what pathology can cause bilateral blurred vision? You're either dealing with something at the bilateral lens. For example, people who are hyperglycemic get lens edema and can have blurred vision from that. And you'll see this in your folks with diabetes. Patients with hyperviscosity syndrome, like Waldenstrom's, leukemias, can have pathology of both lenses leading to blurred vision. Then you can say, can you have a bilateral retinal process? You can, but he's too young for that. Older individuals may have diabetes and macular degeneration that can affect both eyes. So, and retrochiasmatic processes don't usually present with blurred vision, but rather visual field loss that often the patient doesn't know and you have to test for on exam, like bitemporal hemianopsia. So for me, the blurred vision based on the rest of the story goes to the lens, and it really prioritizes some kind of hyperviscosity syndrome. Why hyperviscosity? Because now I'm taking the leap and saying, if there's also splenomegaly, can something be infiltrating the spleen? Can it be infiltrating the bilateral lenses? Can it be causing the priapism from a non-ischemic pathology based on what Robbie described, like leukostasis? And then you have the tinnitus. And the tinnitus too, if you want to loop it in with everything else, is getting this flavor of an infiltrative process. So what are the next steps? The next steps is a very thorough physical exam. And before you do that, I want to share a quick story. When I was a medical student, my ICU attending told me of a case where during Halloween, a gentleman actually injected his penis with cocaine, or injected or put cocaine on his penis, and was having intercourse after like putting cocaine on the penis. And that guy went into a cardiac arrest. But cocaine is another drug that can cause priapism. I think that's less likely here, Robbie, because we have 20 days and we have extra penile clues. So for me, the next step is doing a good eye exam to see if we can really pinpoint this to bilateral blurred vision, specifically the lens, doing an exam for splenomegaly, and then also like doing, testing the cranial nerve 8 just for hearing, just given that we have tinnitus. But I'm worried about a widespread infiltrative hematologic process, specifically something that would be like a leukemia here.
Well, it's really interesting. So now I have the physical exam. And I think from then on, you might have the diagnosis. The vitals are normal. So normal temperature, blood pressure, heart rate, respiration, and SO2 was within normal as well. General, the patient was alert and oriented, and he was in no distress. HEENT, no anemia was found, no scleral icterus, no enlargement of lymph nodes. Abdomen, spleen was palpable, splenomegaly was confirmed, lungs and heart were within normal limits, and the extremities, no edema. I don't have a neuro exam, which probably would be appropriate because of his blurred vision. So the next aliquot will be the laboratory.
Did you all see how he just swoops in casually and just like crushes it like no other? It's superb. Absolutely amazing, Prof. Rez. In many ways, I just wanted to show the audience what you did, because I think you were doing it, is you took everything on the left upper corner, which is so complicated, and you said, actually, there's a common denominator. The common denominator is an infiltrative hematological disease. And I think that's so superb. And now that we've confirmed the splenomegaly, I think that probability is only even higher But it is such a powerful finding to find a big spleen that you want to backtrack and make sure that you've thought it through. And thinking it through is actually pretty simple. So the spleen is big because of one of three reasons. It's either big because it's filled with water, it's either big because it's filled with white blood cells or red blood cells. And it's really powerful. It's really impressive how much power you can get from the physical exam alone. When the spleen is filled with water, there are other parts of the body that are filled with water. And that occurs in patients with portal hypertension who also get ascites and who also get lower extremity edema. So I think we can dismiss pretty quickly the most common cause of splenomegaly by the absence of water elsewhere in the belly and in the legs. And now the question is the spleen full of red blood cells or white blood cells? Now, let me give you examples of each. A white blood cell disorder would be something like lymphoma, and a red blood cell disorder would be something like hereditary spherocytosis or sickle cell or malaria or babesia, all things that go into red blood cells. Now, yesterday, we had a masterclass discussion and presentation by Leah and Omaima about hemolytic disorders, and we learned that they're pretty prominent signature on the exam. They cause a little bit of jaundice, they cause tachycardia. And so the lack of jaundice and the lack of tachycardia has us wondering whether this is a white blood cell infiltrative process of the spleen. And let's just backtrack so this is hammered home how much progress you can make. Spleen full of water from portal hypertension, no evidence of portal hypertension here. Full of red blood cells, usually in the face of a hemolytic disorder, which here would have to be non-tachycardic, non-jaundiced hemolytic disorder causing that big a spleen, doesn't make sense. So the question really becomes, what kind of white blood cell disorder is infiltrating the spleen? Is it infection? Is it autoimmune? Is it drug-induced? Is it malignancy? Or is it myeloproliferative? And really, there's no signature of infection here. There's no drug on board. There's no signature of autoimmune disease. So I think Prof. Rez's hunch, if you think about it slowly, of this being a hematological issue, either malignant, lymphoma, leukemia, or myeloproliferative, is going to be key. And the answer will almost be immediately prioritized on the CBC. If we see cytopenias on the CBC, we'll have to worry about leukemia, lymphoma. If we see cytosis on the CBC, we'll have to think about a myeloproliferative neoplasm. And so I think the answer is going to lie in one of those two things. And I think the law of proportionality would have you probably prioritize slightly a myeloproliferative neoplasm. Why? The splenomegaly is so massive and there's no lymphadenopathy whatsoever. That is a characteristic feature of myeloproliferative neoplasms, which tend not to cause lymphadenopathy. So yesterday we did this and I was horribly wrong about what kind of jaundice the patient had. But I'll tell you, if this case plays out 100 times over, more people will have MPNs than will have liquid malignancies, because leukemias tend to be more systemic, more devastating, more acute, and lymphomas tend to have more lymphadenopathy. But tend is not a word to solidify, it's a word to use, but be ready to be wrong. Anything to add, Prof. Rez, before we learn from Hans what the labs are?
No, nada. But I learned you have a special guest in the adjacent room.
Yes, he was here hanging out. I know.
That's not fair, because I feel like that person's brilliance is just making you more brilliant.
Maybe I'm passively absorbing Kirtan's brilliance, but I want to publicly acknowledge that he is way too shy to hang out publicly with all of you, but got to hang out a little bit with the.
You know what I told him, Robbie? I said that Nar is the prince of the house.
Yeah. Oh, he already
Really
learned
spoiled.
that. He already learned that. I don't know where Nar is actually. Maybe he's bugging Kirtan. Yes, the prince of the house is Nar, who controls all that flows within this house. All right, Hans, tell us more, please.
Yes. Now, basically the last aliquot, the laboratory. We have hemoglobin, it's 10.4 gram per deciliter, a little bit low. White blood cell, I hope I can, it's 400,000, 21,000, so 421,000 cells per millimeter Hi3. The normal would be around 4,500 to 11,000. I have a differential, which is neutrophils 4.3, lymphocytes 6.8, monocytes 81.3, eosinophils and basophils look pretty much normal, 4.9 and 2.7. Blood urea nitrogen has been done as well. It's 9 milligram per deciliter. And the CBC is normal. There's nothing unusual. And uric acid is 6.5 milligrams per deciliter. And the peripheral smear was done. We can do that at the end.
Awesome. Thank you so much, Han. We will tackle this together. I think before we saw the white blood cell count, if you wanted to say that this was sickle cell disease, which was possible prior to the CBC, I learned this in Baltimore because I took care of a lot of patients with sickle cell disease. Usually the ones with the genotype SS, they actually auto-infarct their spleen. So you have a small spleen. But those with SC tend to have splenomegaly and an intact spleen. So up to that point, if you were worried about sickle cell, it would be the SC variant as opposed to the SS. But what this white blood cell count does, it tells us you're dealing with a hematologic malignancy, specifically a form of leukemia. And here is, to be quite frank, I don't have the best approach to be able to, and maybe Robbie can make more progress on the specific type of leukemia. What I can tell you is the following, that when you have blast cells, so when you're dealing with like acute myeloblastic leukemia or lymphoblastic leukemia, you don't need a high quantity of white cells to start getting infarction of organs or leukostasis, meaning a small amount of blast cells can wreak havoc on the system. But when you're dealing with more chronic forms of leukemia, the body has time to adapt. So you really need a high number to start seeing the sequela. Specifically, I think Yasmin mentioned in the chat of stuff like leukostasis. So to me, Robbie, I think the degree of white blood cell count is pointing more towards sort of a chronic variant of leukemia, but I don't have the best approach and would love to hear from you to make more progress on this.
You know, I'm not sure how much more I can add. Honestly, I think that's the inference that I would make. I think I have learned, as you have said many times, to be very careful interpreting the diff, because the manual, the automated diff can be misleading. So I'll just say that. But when you look at the white blood cell and it's high, it's crucial to know the diff. And I organize it in buckets of 3. So on one side is neutrophils, eosinophils, and lymphocytes. On the other side are monocytes, basophils, and blasts. Lymphocytes, neutrophils, eosinophils, monocytes, basophils, and blasts. Now, why this 2 buckets is because most of the time that you have neutrophilia, lymphocytosis, or eosinophilia, it's in response to something outside the hematological system, usually an infection, but can be a drug-induced eosinophilic reaction, or mononucleosis includes lymphocytosis. However, in stark contrast, when you have monocytosis, when you have basophilia or blasts, it's usually a primary hematological issue. The problem is that the machine that Hans's team used to detect this is not perfect and often mistakes blasts for other things. So blasts can be easily mistaken for monocytes or mistaken for lymphocytes. So I would be holding my breath until we learn exactly what those monocytes are. Are they just blasts? In which case, this patient, based purely on the amount of blasts that they have, has acute myeloid leukemia, AML. But if you base it sheerly on if you believe that these truly are monocytes, it has the DDX. We actually had a case on RLR CP solvers of this, where I had the opportunity to dive deep into monocytosis. And monocytosis can be infectious. It can be other things, but the truth is 95% represents a malignancy. And Prof. Rez is right. When the white cell is this high, this amount of monocytosis, it's hard to imagine that this developed acutely. So the most common diagnosis you might render is CMML, chronic monomyelocytic leukemia. However, it is very, very, very unusual for CMML to occur in anyone less than the age of 70. It is just like myelodysplasia, an age-associated disease. So if you see monocytosis over 1,000, you first have to step back and make sure, wait, is this smear misleading me? And is it actually blasts? That's step number one. Step number two is, what is the age of the patient? If the patient is young, they probably have AMML no matter what, because CMML, chronic monomyelocytic leukemia, is an age-related disease. I don't know if there are genetic variants of this, but when I read about it, I didn't come across any, but I didn't look for that specific question. So Profres, just based on the fact that he's 18, I think CMML, unlike our patient who was 85, I would probably be worried that this person has AMML, in large part because I just can't believe that he truly has 81,000 monocytes. I worry that some of those are blasts. What do you think?
I think the 2 points you make are absolutely brilliant. One, don't trust the automated reader. And then two, incorporating the patient's age to pretty much exclude CMML and prioritize AMML. And I think we are worried about blasts there. I think you're spot on. I think those two pieces of data are very important in making progress here. But ultimately, right now, like this is a medical emergency. Like this patient needs plasma. This patient needs their blood exchange because of the leukostasis and their plasma exchange, and needs a bone marrow, needs a smear to really look at those white cells and those blasts, and needs emergent therapy. I think the leukophoresis will be important here, Robbie, because of the symptoms, but then concurrently treating the underlying leukemia. And the one that you always have to make sure it's not is APL, because if you give transretinoic acid, it can be life-saving, but I'm not getting a flavor for acute promyelocytic leukemia. But anyways, those are what I'm thinking. Get oncology on board. Does this patient need leukophoresis? And then starting induction chemotherapy for whatever the most likely that. So it needs a bone marrow biopsy, peripheral flow, and such.
Okay, I think that I can now bring the result of the peripheral smear, and I myself was completely flabbergasted. The blood smear showed leukocytosis, highly suggestive of CML in a very, very young patient of 18 years. And a genetic analysis was subsequently done, and it showed the BCR-ABL translocation, the Philadelphia chromosome. And the leukocytosis, it showed 3% myeloblasts, 6% promyelocytes, 4% myelocytes, 2% metamyelocytes, 5% STAB neutrophils, 63% segmented neutrophils, which is normal, 4% eosinophils, 6% basophils, 5% lymphocytes, 2% monocytes, and atypical lymphocytes. It's just the finding of CML and the genetics that was really completely perplexing because of the age of the patient and of the presentation.
Hans, I'll just say, I think the way I read this is that it's actually can be a little bit confusing when you say CMML and CML. So CMML, 2 M's, and CML, 1 L are very different. Based on the actual peripheral blood smear, I'm not too surprised that this patient has CML, because you're learning that he had 81.3 thousand monocytes per the manual smear. But when you do it properly, you see that actually he has mostly neutrophils, he has basophils, eosinophils, and precursor cells. That is a classic finding for CML. Classic. You see an increase in all the myeloid cells. You said 63% neutrophils. Is that right, Hans?
Yes.
Yeah. So, it goes to show, I mean, if you look at that initial diff of only 4.3 thousand of 421 were read as neutrophils by the automated smear. So I think that it is just so powerful to actually review the manual smear and actually do it that way. Because look at the difference between the diff that that we have up top and the diff that is at the bottom. And if you look at the diff at the bottom, that is pathognomonic for CML, because you see an increase in every single myeloid cell, neutrophils, lymphocytes, basophils, eosinophils. Very, very powerful lesson that you emphasized here today. Professor, what do you think?
I'm blown away by Han and this case that he presents, like very, very educational, because one, we often don't have the chief concern of priapism. So this can serve as a stimulus to actually create a schema. So we'll be better prepared going forward. But once we got the extra penile manifestations of splenomegaly and blurred vision, then we knew we were dealing most likely with hyperviscosity and an infiltrative process. And then I think, Robbie, the white count of 400,000, it's sort of hard to imagine this being an acute process, but rather because you would expect the patient to manifest symptoms much earlier with blast, not 20 days in, and not with this degree of white blood cell count. So I think that value itself, maybe I'm wrong, is leaning you towards more chronic process, which is where you and I concluded, actually, that we're probably dealing with a chronic leukemia. I just don't have the most robust illness script for CML. So this will be another stimulus to create, the CML. And because there's some time, I do want to hear from Han what happened to the patient, but I also want to share a quick screen with the audience. And this is on our, this is actually on our RLR CP Solvers website with an accompanying video. And I just want to show the illness script here. As Robbie mentioned, this is CMML, so 2 M's, myelomonocytic leukemia. And really, all leukemias just come down to some kind of driver mutation in abnormal hematopoietic stem cell, and then proliferation and dysplasia, which then literally bleeds into the blood. So everything is starting at the bone marrow. The age here, greatest risk factor is aging. And this is why we didn't think it was CMML. And then once you are worried about CMML, like just understanding that you can get this AML transformation, but the DX requires ruling out other causes, specifically CML and the BCR-ABL translocation. So I'm just very curious to hear what happened to the patient and to go from there.
Yes, the patient received various rounds of leukapheresis to treat his most immediate symptom. He was first put on hydroxyurea before they had the genetic result, and then he received a tyrosine kinase inhibitor. And yes, he improved significantly.
Absolutely humbling case, Hans. Every single time you've presented, I feel like I've learned so much. Truly. I don't have a schema on priapism. That'll definitely be something that I try to work on. And then just so humbled by when you're solving the problem and you're led astray by a piece of inaccurate data, it just goes to show you how if you solve this as monocytosis, you're just solving the wrong problem. And so I think just knowing how data can be flawed it's just so powerful. So thank you. I'm curious, Hans, what did you take away from it? What did you enjoy about this case and learn from it? I don't know if you caught that, Hans. Hans, can you tell us what you enjoyed about it? What did you take away?
First of all, that we have such a strange manifestation of CML. I am always thinking about maybe bleeding gums and other things, but I would have never thought a patient come in with a symptom like this and come down with such a devastating diagnosis. We can control it, but I think we can't completely treat it or cure it. I'm not sure. Those direct inhibitors for the tyrosine kinase, he can get immune against it, or some resistance can be formed later on. But I was very surprised to see that we were able to help him, not with the first treatment because there was no definite diagnosis, but later with a genetic analysis. And the strange symptom that the patient presented himself with in the AR. It's completely perplexing. Yes, and besides, I have learned that about 20% of all priapism are somehow related to hematological disorders, sickle cell disease being one of them, but all the kinds of leukemias like ALL, etc., have to be considered.
So much wisdom there, Hans. Thank you so much for sharing this case. I'm really glad that you took the leap and taught us so much today. Amazing. Thank you for your time, and I'm excited to do a run through with Danya.
All right. This was, first of all, I hope you guys can hear me, but this was, can you hear me? All right.
Yes, loud and clear. Yeah, go for it.
All right. So this is such an amazing case. I learned so much. So thank you, Hans, and thank you, Ravi and Raza, for teaching us all of this. So today we got a case of priapism, and priapism is basically persistent erection that is longer than the physiologic time. So whenever there is a patient that presents with this complaint, we need to first assess whether this is intermittent or persistent. And the basic pathophysiology behind this is outflow obstruction. Now, there are certain etiologies to priapism. There can be trauma or any neurogenic causes like spinal cord injury or neurosyphilis, then any infectious causes, blood disorders, and by that I mean either sickle cell disease or thalassemia, then metabolic disorders or any hematologic malignancies. We discussed a few of them today. Or there are a list of medications, a few of them Rabi mentioned, and then there are antidepressants as well that can cause priapism, alcohol use, any toxins or insect bite. Another way to categorize priapism is either whether to identify whether it is ischemic or non-ischemic. By that, I mean whether there is an obstructive cause or a high blood flow going to the penile vasculature. And although non-ischemic causes are rare and they resolve on their own, we still need to try and rule out those causes. So the case that we had, it suggested, and according to Raza, it suggested an extra penile cause because the patient complained of an enlarging left stomach, and by that we probably thought this was enlarging spleen. And so with that, we're going to try and find out what can cause an enlarging spleen. It can either be water, in number of WBCs, RBCs, or any molecules like amyloid in the spleen. So I'm sorry, the font is so small, I cannot also read it myself. All right, so this particular case, we thought this was probably a myeloproliferative neoplasm, as there is no lymphadenopathy associated over here in this particular patient, and the complaints that the patient had of tinnitus and blurred vision, we were leaning towards Waldenstrom macroglobulinemia, which has blurred vision, tinnitus, as well as splenomegaly. But at the end, we found out that this was chronic myelogenous leukemia because the patient had an increased number of neutrophils and myeloid cell lines, and which was a rare presentation because initially we saw that the WBC count was extremely high, and we learned a little about CMML, which is an age-associated disease, and that has features of both myeloproliferative neoplasm as well as myelodysplastic syndrome. These patients may also present with recurrent infections, bleeding disorders, weight loss, as well as splenomegaly that the patient had. But for that, usually CMML is very rare and usually presents in patients who are more than 80 years of age. This patient, however, had CMLs, another disorder that is usually present in patients who are of an older age demographic. But this is a disease where there is an increase in all myeloid cell lines. Usually it has Philadelphia chromosome positivity, which is BCR-ABL translocation. This particular disorder also has a PPHL change, which is basically characterized by hypersegmentation of the neutrophil nucleus and chromatin clumping on the peripheral smear. There's also a very high eosinophil and basophil count, as well as on lab diagnosis, we can see that there can be usually a low leukocyte alkaline phosphatase count. And associated complication can be blast crisis, which can be seen as a very large spleen. I hope this was a good summary. I don't know, there was a lot of information, and yeah, I was just really excited to learn.
And Dania, it's
Thanks.
every time that Hans presents a case, I think the teaching points become a monumentous challenge. So I think you did a masterful job summarizing a very, very complicated case. So thank you. And if you are feeling anxious about it, you should 100% blame Hans's amazing cases. We really, really appreciate you, Hans. Thank you. All right. See you all next time.